Good evening, doctors. My name is Dakshata and I am from Glenmark Pharmaceuticals. And it gives me immense pleasure to welcome you all for today's scientific session titled From Evidence to Practice, a Role of Fluticasone Furoate and Vilantrol in Asthma Management. We all would agree that asthma remains a heterogeneous disease over past few years, and vilantrol fluticasone combination has emerged as an important option owing to its once a daily dosing, sustained bronchodilation, and strong anti-inflammatory efficacy profile over other conventional ICS LABAs. Today's discussion will highlight patients on uncontrolled patients on conventional twice a daily ICS LABAs and current Indian evidences of fluticasone furoate and vilantrol in different asthmatic patient profiles. With this now, I would like to introduce and welcome our speaker and moderator for today's session, none other than Dr. Ronald. And today's speaker and our panel need no formal introduction. So if I have to talk about Dr. Ronald, then he's MD Respiratory Medicine, and he's assistant professor of CMC College, Imphal. So Doctor, welcome for this webinar.
Thank you.
Then we have Dr. N. Deka. He's a senior consultant at Nagaon, Assam. So, Doctor, welcome for this webinar.
Welcome.
Then we have Dr. Jayashree Das, who is MD Respiratory Medicine, and currently she's based at AIMS Guwahati. So, Doctor, welcome for this session.
Thank you.
And last but not the least, we have Dr. Vilubu, who is also MD Respiratory and he's Associate Professor at GINMS, NIMS Impahal College. So, Doctor, welcome.
Thank you. Thank you.
And before I hand over the session to our speaker and moderator, Dr. Ronald, this session is brought to you by the makers of Vilorev, which is a combination of fluticasone and vilantrol, MDI, DPI both, and Vilor FG, which is a combination of vilantrol, fluticasone, and glycopyrronium, MDI, DPI both. Now, with this, without wasting further time, I would love to hand over the session to Dr. Ronald. So, Doctor, over to you now.
Thank you. So good evening, everyone. So today I'll just have a quick presentation. Everyone able to see my screen?
Not yet.
The presentation?
Yeah, now, perfect.
Okay. Okay, so today I'll just be talking in brief regarding the role of fluticasone and vilantrol combination, especially in the management of bronchial asthma. So today's what and all topics things we'll be discussing about. First will be the current challenges in bronchial asthma, a little bit of about the ZINA guidelines 2025, and the need of looking beyond the conventional treatment, and introduction and pharmacological benefits of fluticasone and vilantrol combination. Experience in the new users will be discussing among the panelists, and Indian clinical evidence in uncontrolled patients. Then the use of this combination in persistent asthma, frequent oral corticosteroid users, and clinical remission as concept. And at last, we'll have a little bit panel discussion about this topic. So we all know regarding the bronchial asthma, it has a high symptom burden and is defined as a chronic inflammatory respiratory disease characterized by the episodic symptoms such as difficulty breathing, coughing, and wheezing. And according to the global burden of disease in 2019, it is estimated around 26.2.41 million prevalent cases globally. And India has the highest number of asthma patients worldwide, accounting about 13% of all asthma cases, with asthma-related deaths making up 42.3% of the global total. And pathological process of asthma starts after the exposure to a triggering factor, leading to bronchial hypersensitivity, inflammation of the airways, and excessive mucus production. Management. So the long-term symptom control are the few or no asthma symptoms and quickly relieving no sleep disturbance, and unimpaired physical activity. Long-term asthma risk minimization are no exacerbation, improve or stable personal best lung function, no requirement for maintenance oral corticosteroids, and no medication side effects. So these are the goal of asthma management according to the Zina guidelines 2025. This bronchial asthma patients, I won't go in details about this. We just basically the two tracks. We have the for one which starts with the ICS or formoterol combination, also known as a smart therapy, or the alternative where we can use any other LAVA other than the formoterol along with the ICS combination. So this is the main stepwise treatment of bronchial asthma. I won't go into details regarding this. So the high burden of uncontrolled patient on smart therapy. We are all aware regarding the smart therapy, that is the formoterol and the ICS combination, mostly the budesonide. So this formoterol and budesonide is the most preferred ICS lava. However, 44% of the smart treated patients are uncontrolled with 3 or more undesirable symptoms and 38 partially controlled. Plateau outcome with one size fits all approach, especially with the use of formoterol budesonide combination. There's a history of frequent examination, nighttime symptoms, and ER visits, poor adherence, drives to relapse, rescue inhaler dependence, patients with cardiac disease, obesity, diabetes, or arthritis needs more targeted solutions. Potent ICS with higher receptor efficacy at lower dose and highly selective, and once daily regimen which helps in the factors which affects the this asthma. So why this budesonide? So it is one of the most binding affinity with the lowest oral bioavailability, reducing systemic side effects, and it has a better bronchoprotection with when compared with budesonide. So it has a sustained and clinically meaningful bronchoprotection when compared with budesonide. And another ultra lava, that is the vilanterol. So we are all aware regarding the this role of formoterol in the management of bronchial asthma, but this new drug that is not that new, we are all aware of this drug, but the introduction of this ultra lava vilanterol, it is more effective and it has a more sustained efficacy as compared with bilateral. So 2400 times more selective for beta 2 receptors, and it has a more rapid onset in the acute exacerbation, and no significant effect on the QT interval. It has a sustained 24-hour bronchodilator action, so longer duration of action as compared with the formoterol. So what are the clinical evidence regarding this combination? Newly initiated in patients, especially in the uncontrolled, who are already on conventional therapy. That is the formoterol budesonide combination. So the recent real-world comparative evidence, they have compared the effectiveness in patients with asthma newly initiating with fluticasone furoate and vilanterol combination when compared with the formoterol and budesonide combination. So in this study, they have found 42% low rates of exacerbation with this new combination, 36% low rates of exacerbation with this new combination, and 38% low rates of exacerbation with the formoterol vilanterol combination, especially in the low to medium dose when comparing. So these are the we are seeing in this study. So consistently, it is superior than the formoterol and the budesonide combination, which reduces the time to first exacerbation with statistically significant benefit. So the rate of asthma exacerbation. The formoterol vilanterol can reduce the asthma exacerbation with numerically lower rates compared with the formoterol budesonide, almost 30 to 36%. And the compliance, obviously, with the use of formoterol, fluticasone, and vilanterol as a once daily use, it has significantly lowered the discontinuation rate, and also lowered the mean number of oral corticosteroids prescription. Formoterol budesonide does not outperform treatment with regular OD, this fluticasone Vilanterol combination, but it offers improved long-term treatment persistence and outcomes in newly initiated asthma patients. So we'll talk about the Indian clinical evidence now. This is a prospective open-label multicenter study in the Indian asthmatic patients. The patient population are more than 12 years, prescribed on fluticasone Vilanterol as DPI, and pre-bronchodilator value of 40 to 90% FEV1, uncontrolled on twice daily conventional therapies, and XCQ score more than or equal to 1.5. So these patients, they are screened and then followed up. So these are the patient demographics. Previous therapy with the formoterol budesonide combination, that is a smart therapy. Mean age is about 44 years, and the baseline lung function FEV1 of 1%. And the baseline symptom score, the mean SEQ score is 2.5. So these are demographics. So our findings from this Indian study found that there is improvement in the TRUP FEV1. This new combination saw significant and sustained improvement in the TRUP FEV1, improving the lung function after 12 weeks. And the TRUP FBC is also significantly improved when compared with the after 12 weeks. And SEQ score. The new combination showed significant and sustained improvement in the asthma symptoms with reduction in the nighttime awakening, breathlessness, and improved activity limitation. And the reduction in subsequent exacerbation, almost half of the enrolled patients reported history of exacerbation in the past 1 year, and out of this, 62 of the subjects had reported history of more than 2 exacerbations. After switching to this new combination, only 5% had exacerbation. So this is a significant improvement in reduction in the rescue medication. So we have seen that it has shown that inhalers when switched from the conventional therapy, fluticasone and vilanterol combination. Drug in patients uncontrolled on smart therapy. So on switching to this new combination, it resulted in better symptom control and enhanced lung function in patients who are uncontrolled on the smart therapy. And regarding, we have discussed about the uncontrolled. Now regarding the persistent asthma, although airflow obstruction that is variable and reversible is a defining feature of asthma, there are few subgroups of patients with a long-term persistent asthma who may develop fixed airflow obstruction. So the prevalence of the asthma patients with a fixed airflow obstruction increased with age as a whole, and 45% of the patients older than 50 years of age showed this fixed airway obstruction, and is associated with inflammatory profile consisting mainly of T lymphocytes, macrophages, and neutrophils. Studies also shown that it is not only a disease but also in considerable proportion of patients with milder disease. So in patients with mild asthma, this fixed associated air obstruction is associated with eosinophilic inflammation and a higher risk of exacerbation. So how, as a subgroup analysis of this PROMISE OD study, which was conducted only in patients with persistent asthma, patients were switched to this OD fluticasone vilanterol combination, and they saw significant improvement in the TRUP FEV1 value at week 4 and week 12. And these patients may be considered, and it is continued to be moderate to severe asthma before considering triple therapy or biologics. So this drug combination, before escalating to the triple drug therapy, it can be considered if the patient is already on the smart therapy of formoterol and the budesonide combination. And patients who are uncontrolled on frequent oral corticosteroid users, uncontrolled asthma identified by the GINA are patients either with frequent exacerbation more than 2 per year, more or equal to 2 per year requiring oral corticosteroids use, or severe exacerbation more than 1 year requiring hospitalization. So this is how we define a uncontrolled asthma. And study reported 7 out of 10 severe asthma patients as frequent exhibitors. And frequent exhibitors are characterized by the use of high dose oral corticosteroids, worse asthma control, lower quality of life, high sputum eosinophils, and a rapid decline in the FEV1 by the FVC ratio. So this combination in patients with frequent OCS users, so this study showed that it has a high patient adherence in patients experiencing frequent exacerbations on conventional therapies, leading to the improved asthma symptoms and high patient satisfaction. Around 95% were integrated in this study, and 98% no longer fear about the incorrect medication, and almost 96% feel convenient to carry and use this combination. So this adherence is also improved, especially in the OCS users in the frequent exacerbators. So this is another study where the ICS ultralava in the treatment of obstructive airway disease. This is from the Indian study. So they proposed the asthma management using this fluentral and vilantrol combination. So this is a recommended positioning, especially in the step 3, step 4, and the step 5 combination. So here they are suggesting the medium use of this ultra lava and ICS combination, that is nothing but the vilantrol and the fluticasone combination. So the key takeaway points of today's discussion: despite the conventional therapy, there is a high burden of uncontrolled asthma patients in India. So treatment choice based is on treatable traits should be tailor-made rather than following one-size-fits-all approach. Vilantrol is a potent selective beta-2 agonist with rapid onset, long duration, and high intrinsic activity. And fluticasone furet has a high affinity, negligible oral viability, and superior potency and wider therapeutic index when compared to the fluticasone formoterol budesonide combination. So Indian evidence has also shown efficacy of this new combination in asthma patients with persistent asthma and high symptom burden and high reliever use patients. So with improvement in the asthma symptoms, significant reduction in subsequent exacerbation, and hence reliever use was observed. So high patient satisfaction and adherence also contributed in improving the quality of life in uncontrolled asthma patients. So that ends our today's presentation. So shall we move on to the panel discussion straight?
Yes, doctor. Yes.
Fine. So uh, I would like to, I guess, yes. So I would like to. This is a thing we'll be discussing with all our panelists, I guess. So I would like to ask everyone to share your experience. What are the earliest clinical warning signs that asthma control is deteriorating even before the lung function declines? That is from your spirometry. And should nighttime awakenings, early morning symptoms, or reduced exercise tolerance be considered as signs of asthma control?
Uh, Hello.
Yes, sir.
Uh, yes, let me take the first opportunity. First of all, I would like to thank the Glenmark Pharmaceuticals respiratory cares for giving me this privilege to be the panelist of today's discussion. And yes, I would like to congratulate Dr. Ronald for his wonderful presentation, a very nice presentation, very conscious to the points, and everything is there of what we want to know about the bilanterol and fluticasone furet in treating the bronchial asthma patient. So, yes, without much delay, I'll just go to these questions. And yes, to know that a patient asthma control symptom is deteriorating or not well properly controlled, if a patient is use the relievers or the rescue medication, rescue inhalers, yes, like frequently, like more than 2 times in a week, or he, yes, use frequently the reliever medication, then yes, his asthma symptom is not well controlled. And then yes, if because of his asthma symptom like shortness of breath or difficulty in breathing, chest tightness, because of coughing, is if his sleep is disturbed or there is nighttime awakening is there, then his asthma symptom is also not well controlled. Or when he wake up early in the morning because of this chest tightness or shortness of breath or coughing, and immediate need of the use of the this medication, the inhaler is there, then his asthma symptom is also not well controlled. And then yes, this one, as Dr. Ronald has also said in his slide, there's this one, reduce exercise tolerance. Yes, if there is reduced exercise tolerance, is there like a patients, he can walk for morning walk before, or if he can climb upstairs before, but this kind of activities become a problematic for him because of his shortness of breath, then it's also a condition that his asthma symptom is also not well controlled. And then other than this, if a patient have lots of mucus production is there, increase in wheezing is there, chest tightness is there. And then when patients when exposure to a non-trigger, yes, if yes, have this asthma symptom very easily, then his asthma symptom is not well controlled. Yes, like here's in the question mentioning that nighttime awakening, reduce exercise tolerance, and then yes, this early morning symptom. All these are the yes predictions of the this one impending
Impending
exacerbation. Yes,
exacerbation.
yes, yes.
Mm.
And then this can yes easily this yes, if we don't treat the patient properly, then this can lead to the exacerbation of the asthma. So that's what I want to say. Yes.
Thank you very much, sir, for sharing your experience. Dr. Nagendra, sir, would you like to share your experience?
Thank you very much for actually including me in the panel. It's very nice that one of our panelists, has Dr. Olivio Pame, has explained the symptoms, clinical version very nicely. Actually, these are the things which we actually notice to the patient, and we explain to the patients that if you experience this sort of symptoms, uh, you should uh, consult, or sometimes we tell them to take the rescue medication in this earlier. And in some cases, we used to provide them the piclometer. Also, if they find any difficulty or any find any changing or after being exposed to a trigger, known trigger, if they can quantify their actually FEV1 with this one, the
Spirometry, sir.
spirometry, not that this one is handheld
Oh, yes,
device.
yes.
Yes,
Peak flow meter.
kilometer.
Mm.
They can measure it by themselves and take the measure, preventive measure to avoid the situation. Because
Yes, sir.
at the beginning of the attack, it is very important that the topping up of the inhaler actually helps the patients to go to the further step of exacerbation. Thank you so much.
Thank you so much, sir. Dr. JC, would you like to add anything?
Thank you so much for including me as a panelist. I would agree with whatever you have said, like worsening of the exercise tolerance then night awakening and early morning symptoms, as Willibo sir has already mentioned, increased
Yes.
use of the rescue medications. That is also one of the earliest clinical signs. So these clinical signs would be coming up much before the spirometry changes, I suppose. And based on this clinical signs, only we can update the treatment of our patients.
So yes, so after hearing from all our panelists, so it is, I think, come to the conclusion that the patient's clinical symptoms, they are the ones which we should be monitoring, mainly focusing on, instead of the spirometry. The spirometry comes later. So the symptoms, patient symptom control. So even after the prescribing, our work is not over by just at the end of the prescription. So we should be monitoring the patient's symptoms, and that is how after taking the monitoring the patient, we will come to know whether the asthma control is proper or not, and make sure. And after noting down all these symptoms, we see the clinical warning signs for the whether the asthma control is improving or deteriorating. Fine, we'll move on to the next. So, what advantage have you observed with the this fluticasone vilanterol combination apart from the adherence and compliance in your asthma patients over smart therapy? Please share your experience.
Okay.
Yes, sir. Dr.
Let,
Wilu, sir. We'll start with you.
let me, yes, yes. I'll start with me again. Yes, yes. Yes, there are many
What is your
advantages.
experience of this
Yes,
new?
yes, yes. Yes, yes. Advantages of these molecules, the vilanterol with fluticasone furet. Yes, yes. In we know from Dr. Ronald presentation also that this vilanterol, no, it gives
Yes.
sustained 24-hour bronchodilation. So it is an ultra long-acting bronchodilators. So it is very convenient to use as once daily dose, and then it has rapid onset of actions, like they said, 3.45 minutes. It's a very quick onset of action is there, and
Yes.
then it has no significant effect on QTC interval is there. It doesn't have any effect on the heart rate or the blood pressure, and also
It
it
has a
has,
good safety profile.
yes, 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 and also this one, it has a high selectivity for beta 2
Beta 2.
receptor, no?
Hmm.
So then it can be used very safely for the having patient who have cardiac comorbidity also. So it is a very good drug. And when we talk about the fluticasone furet, it is what is very potent ICS also, and then it
Yes.
has a highest affinity for glucocorticoid receptors, and then lowest oral bioavailability is there, thereby reducing the systemic side effect.
Hmm.
So this, and then it has give broncho protections than the budesonide. So it is a very good drug in combined with the vilanterol. So when we talk about these two combined together, it has consistent superior this one over the conventional one, that is formoterol with budesonide, in this in reducing the exacerbation also. Therefore, this overall this exacerbation of asthma will be reducing, the overall asthma exacerbation will be there. And then it has the significant and sustained improvements in the FEV1 and FVC also there. So thereby overall lung function improvement also will be there. And then it has a significant and sustained improvements in this improving the asthma symptoms, thereby reducing the night awakenings, the shortness of breath, and then yes, improving the even the exercise this tolerance also. Yes, so it is a very good. It has lots of advantages, and then it has yes, and then it said that combination of these two, this molecule, it's even the use of the rescue inhaler is also use of this one also reduce. And then yes, even the glucocorticoids, oral glucocorticoid uses also, it's a significantly, it's by this molecule it can reduce this. So it has, yes, when we see all these things, then it has all the advantages. And then when we look in the molecule or inhalers of yes, to treat the bronchial asthma. So all the what to say, the points, the yes, the yes, which we look in a molecule, that is all there. So it's a very good drug. Yes, it has a lots of yes, definitely it has a lots of advantages, and then over the conventional ICS and LAVA. Yes, I would like to say.
Yes. Thank you, sir. Dr. Nagendra, sir, would you like to
Yes,
share your
yes,
experience?
very nicely explained. And I have been using this molecule for quite a long time since the introduction uh, from the company, and with high symptom burden patients, and along with this pressure uh, with the MDI, actually
Yes,
is a very boon uh, for the patients, because in many of the cases we have to give nebulization, but with the spacer device, with a very immediate acting the formulas and the longer acting, they actually given the benefit of the early symptom relief along with the longer symptom relief, the combination of these two, as the uh, molecules are very actually very nice for, as you have explained, the previous moderator has explained very well, and we are finding it very useful. And with the proper device and proper inhalation, it brings about the relief to the patients in most of the cases. Thank you.
thank you very much, sir. Dr. Jayashree, would you like to add?
Yeah, I would agree with the rest of our panelists. Both the LABA component and the ICS component, that means compared to the smart therapy, both vilanterol and fluticasone, they have much more added advantages as compared to the conventional smart therapy. And sir has already listed out all the advantages over the our conventional smart therapy. So, like sir has mentioned, the LABA component, the vilanterol, it has a more sustained duration of action, and it has lower beta 2 agonist side effects, and then it has a better cardiovascular profile. And coming to the ICS component, the fluticasone furet is a much better molecule as compared to budesonide, with more potent action, and it also has a finer molecule size which can reach the terminal part of the airways, and so it provides more better anti-inflammatory and prolonged anti-inflammatory effect. So I think fluticasone furet and vilanterol combination has a much better advantages as compared to our smart therapy. I would agree with that.
Thank you. Okay, so next will be, in which patient's profile or traits have you been currently prescribing this new combination, that is the vilanterol and fluticasone combination? So I would like everyone to just share your patient profile, like on which patients, especially in the asthma patients. So just I would like to everyone to share. So shall we start with Dr. Jayashree this time?
Okay.
Mm.
So basically, as you have already mentioned in your presentation, like the patients who are mostly uncontrolled, the patients who are having uncontrolled symptoms. So basically, not in step 1 or 2, would be starting in the step 3. So in the step 3,
Why not step one or step two? Why not?
step 1 and step 2 patients, I think they are having more of less of the clinical symptoms, or with lesser of this nocturnal predominant symptoms. They are less symptomatic. So maybe we can go with our conventional therapy. But in certain phenotypes, I agree with you. Like in certain phenotypes who are having nocturnal predominant symptoms and patient who are having persistent symptoms, I think we can go upfront with the vilanterol and vilanterol and fluticasone combination. But in step 3, we can actually go for this ultra laba molecules, and
Mhm.
also in certain patients who are obese, patients who are having BMI for more than 30, and who are having dyspnea predominant symptoms, and they are having more of decreased more of exercise intolerance. In these
Mhm.
patients also, I think fluticasone shows a more promising result as compared to budesonide. And patients who are having sensitive to all the beta agonist side effects, in those patients also we can go upfront with this combination. And like we have already discussed, patients with nocturnal predominant symptoms, persistent symptoms, we can go upfront with this combination.
Thank you. Dr. Wilu, sir, would you like to add?
Yeah. This, yes, we can, yes, use in an uncontrolled asthma patient. Now, because we have already talked about the advantages of this drug. Now, it will
Yes.
improve the FEV1 and it will improve the FVC also, thereby improving the lung functions. Now, thereby, and then it also has this one significant and sustained improvements of the asthma control also, like it will reduce the nighttime awakening, nighttime coughing, nighttime shortness of breath. So, yes, it will reduce the even the exercise tolerance also. So yes, we can give in
What
an
about, sir, in
uncontrolled.
newly diagnosed patients?
Yes, yes.
Newly diagnosed.
For considering all the good about the bilanterol and this futication furet, I
Yes.
think, in my opinion, too, I can definitely start for all the newly diagnosed case of the asthma also, because it give a long this one bronchodilation. It give the, yes,
The
ventricle
patient
sustain.
adherence. The patient
Yes,
adherence.
and then
Yes.
yes, patient adherence is very good also. And
Yes.
then there are some people, yes, who find it very difficult to use twice daily
Exactly.
these things. Yes, if a patient, yes, can use once daily, na? So then
Yes.
the patient adherence also will be very good. So
Yes.
then if patient adherence good, then the drug this effectiveness also will be very good. So
Yes.
I think yes, it will be very good to start even for the newly diagnosed case of the bronchial asthma also. And
Mm.
then yes, the time will tell us. But yes, I feel that this combination, Vilentro with futication furet, in times, not this may even replace the conventional one also.
Smart
Because
therapy.
yes, 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 smart therapy.
Mm.
Because
The new smart
all the
therapy.
good quality about the drugs is there
Mm.
in Vilentro
Yes.
with futication furet. So
Yes.
that's, I want to say, yes, yes. And then yes, yeah, yeah, yeah. That
Thank you,
is.
sir. Yes, Nagendra, sir, would you like to add your experience?
Actually, with a very high symptom burden patients, there is actually this is the molecule of combination of choice, and actually it is being explained very nicely with a compliance of once daily, with improving the lung function and providing better relief, and is a molecule of choice from my side also.
Thank you, sir. So personally, from my end, yes, as we discussed, so all this uncontrolled asthma, then we have the persistent asthma. Also, all this high burden with frequent exacerbators. All this we can try, but yeah, the main thing which we, yeah, especially in the stage 2, stage 3, and even stage 4. So yeah, before in increasing the dose in the smart therapy, so we can try this formoterol bilanterol. So that has been shown more efficacious, and it has more control of symptoms, as we discussed. And personally, especially my patients who wants to wants to use very less of the inhalers, who doesn't want to, who like wants to stick with just a once daily treatment. So even in the newly diagnosed patients, so I try and put them on with this this fluticasone and bilanterol combination, and they have actually shown very good control actually. So we'll move on to the next. So if the patient is uncontrolled on low dose formoterol and budesonide combination, what is your preferred approach? So these are the steps: escalate to medium or high dose with the formoterol budesonide, or switch to this fluticasone bilanterol combination, or escalate to triple drug therapy. There is the glycopyranum formoterol budesonide combination, that is the BID dosing, or the triple drug therapy of bilanterol, fluticasone, and this OD dosing, glycopyranum. So please, Dr. Nagendra sir, would you like to share what will be your preferred approach if the patient is uncontrolled on this low dose formoterol budesonide combination?
Uh,
What will be your next preferred
Next
step
prepared
up?
actually step up or the efficacious next one, I think we should try this and switch over to this combination FF and B1, and
Yes, sir.
uh, before going to triple therapy,
Yes,
because
sir.
in most of the cases we have found it uh, uh, in without giving the smart therapy twice daily, which is inconvenient, or it is not effective, or escalating the dose of that molecule also. This molecule, if it is given once only, in most of the cases, it works. And I think first we should try this one, switching out to uh, FF and B1.
Thank you, sir. Dr. Willu, sir, would you like to add your
Yeah,
comment?
yeah. Here, I would like to say that they're switching to this Vilendoro with futication furet will be a good choice because it will, yes, improve the this lung functions, and then it will improve the this asthma control also. So yes, and then it even reduce the this exertion also. So yes, switching to this Vilentro with futication will be right choice instead of stepping up the this one, escalate to medium to high dose of formoterol. Yes, that's what or stepping to this one triple therapy. You know?
Yes,
Yes,
sir. So
yes, that's
let's say the patient is still having exacerbation after switching to this Vilantrol and fluticasone combination. So what will be your next step, sir?
yes. Then we have to switch to this triple therapy. Triple
So
therapy.
if you are going
Yes.
for the triple therapy, which combination, sir?
Yes, if patient is not having this one, what to say, like nighttime symptom, this and that, then I will prefer giving this triple combination with fluticasone, furet with bilentro with umuclinium also. Yes,
Hmm.
because if the patient is having yes no night symptom of frequent symptoms are not there, then this once daily dose will be very good. But if patient is having nighttime symptom, nighttime awakening, and then yes, then I would prefer for this twice daily doses.
Twice
Yes,
daily with the formoterol combination.
yes, 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 yes.
Thank you, sir. Dr. Jesse, would you like to add your comment? What
Yes,
will
I
be
would
your
agree.
preferred
I would
approach?
agree. Yes, I would agree switching to fluticasone furet and bilantrol. But prior to that, what we basically do in our clinical practice is we recheck. We recheck the inhaler technique of the
Exactly,
patient.
exactly. Yes,
We see the actual use pattern of the patient, whether the patient,
yes,
how the
yes.
patient is using the maintenance and the reliever medication. Apart from that, we need to check the trigger load. Like if their patient is having any other comorbid conditions like rhinitis, GERD symptoms, and if the patient is an active smoker, if there is biomass exposure, and we
Hmm.
also check the adherence. And apart from that, if the
The
patient is
sputum
still
eosinophil
having
count also.
yeah, yeah. If the
Hmm.
patient is still having the uncontrolled symptoms, we can definitely switch to this fluticasone and vilanterol combination. And apart from that, if the patient is still uncontrolled, we can go to the triple therapy.
So if you are escalating to triple drug therapy, what will be your drug of choice? Will you do give a BID or OD dosing?
I think Sir has already answered this. I think there has not been any head-to-head trials regarding
Yes,
the
yes.
triple
Mm,
therapy
mm.
combination. So, if the patient is definitely having more of nocturnal symptoms, then we would go for a BID dosing. And if the patient is like not having as such, no, like no that significant nocturnal symptoms, then we can go definitely go for the once daily dosing combination.
Yes, but yeah, from my experience, from what I feel, if the patient is not effective, even after escalating, let's say to the this thing, high dose, or let's say we have switched to the formoterol vilantrol combination. So if the patient is still complaining of exacerbation, then I'm pretty certain he or she will be having the night symptoms also.
Mm.
So we will be forced to convert to the triple drug therapy. So if if let's say the patient is having this the night symptoms also, then early morning symptoms also, do you feel that this triple drug combination of this vilantrol, glycopyrronium, and this fluticasone combination won't be that much effective as compared with the BID dosing? Like we have compared this smart therapy, right, with
Yes.
the formoterol and the budesonide combination with the this fluticasone and the vilantrol. So one is the OD dosing, one is the BD dosing. So I think the same principle applies in the this triple therapy also. So the in the triple therapy where the BID dosing is there, we have this formoterol with the budesonide and the glycopyridine combination, and the other is the vilanterol and this fluticasone with the glycopyridine combination. So do you think that this OD dosing won't be as effective as the BID dosing?
No, no, OD dosing will also be effective because we have got the better molecules. Like compared to budesonide,
Hmm.
we are having
Hmm.
fluticasone. So I think, and vilanterol is comparatively better than
Hmm.
formoterol combination. So I think vilanterol will be more effective even though it is OD
Ah,
dosing. But
that is personally what I feel, and yeah, I have tried a bit in a few of my patients also, and they have shown quite efficacious actually, even with the night control symptoms. So this OD dosing with the triple drug therapy, it has shown quite efficacious when the patient was not controlled with this the dual drug therapy. So yeah, everyone is correct. Obviously, we have to escalate if the two drug therapy does not improve the patient's conditions in spite of checking the proper inhaler technique and everything. Yeah, so obviously we'll have to escalate to the triple drug therapy, and of course we could think about adding the oral corticosteroids also. But yes, this triple therapy with this OD dosing of this three combination, it is also shown quite good efficacy. Thank you. So we'll move on to the next. So when do you label a patient as difficult to treat asthma? Your approach to patients with frequent oral corticosteroid users more than or equal to two exacerbations per year on formoterol and budesonide combinations. Nagendra sir, shall we start? What is
Um,
your experience?
mhm. Actually, this patient is having frequent exacerbations uh,
Yes, sir.
with frequent OCS users more than two
Yes.
times per year
Yeah,
uh,
on the smart
on
therapy.
on one. So in this case, actually, the higher dose were long-acting better combinations. Switching to whatever we have discussed, FF and B1. This is
Yes, sir.
another one, and the triple therapy may be uh, of use in these cases because of the bronchodilator action of these two groups, F and G, uh, the muscarinic and the ultralava, along with ICS, will be better for the symptom relief. Uh,
So, sir, from what I'm getting, for if the patient is on formoterol budesonide combination with oral corticosteroids, so we'll first switch to this two drug combination, and if that doesn't work, then we'll switch to the triple drug therapy, right?
yes.
Okay, thank you, sir. Dr. Wilu, sir, would you like to add your comment?
Yeah. Yes, according to the question, when do we labels a patient as difficult to treat asthma? Yes, difficult to treat asthma is an uncontrolled asthma actually. So, uh, uncontrolled asthma, which asthma symptoms are poorly controlled in spite of we are giving the what it says this one adequate treatment. Uh, yes,
Mhm.
his symptoms are poorly controlled. So when we talk about difficult to treat asthma, we need to know about this one, uncontrolled asthma. Also, from uncontrolled asthma, we divided into this difficult to treat asthma and truth severe this bronchial asthma. So this difficult to treat asthma has many modifiable risk factor also. Modifiable risk
Yes,
factors and then yes comorbidities. When we talk about the modifiable factors, the patient may be associated, bronchial asthma patient may be associated with having GERD, allergic rhinitis, as Dr. Jayashree has pointed out, and then the sinusitis or OSA or this yes OSA and then obesity. So if we don't take care of all this problem, even if we treat
yes, sir.
the bronchial asthma, the symptom will not be well controlled. So and then
Mhm.
one
So
important
we should
thing is
address the
about
other
the yes,
comorbidities also.
we have to see the
Yes, sir.
adherence also when to level
Yes,
the
sir. Yes.
bronchial difficult to treat asthma.
Mhm.
If patient is not
Mhm.
using the inhaler technique correctly, or if he is not using the adequate doses, then the treatments will not be effective. So after this correcting all these modified factors, comorbidity,
Comorbidities.
yes, yes, everything, if patient is still having the symptoms, and then yes, still having the symptom, then we'll label the patient as true severe bronchial asthma. Otherwise,
Mm.
difficult to treat asthma is after ruling out everything, and if we treat properly, the patient will surely respond to the treatment. So, yes, for true severe bronchial asthma, though, we only comes after this one, let's say 6 months after we treatment, we came to know that, oh, this is really true severe bronchial asthma. At the first beginning, we cannot label true severe bronchial asthma also because that has to be treated by the expert, yes, the pulmonologist, and then still the symptom is not able to control. Then that only then we have to label it as true severe bronchial. Otherwise, that after correcting all the modified factor comorbidities, and then if we treat properly, then difficult to treat asthma will surely respond also. So yes, this patient has this has frequent use of the
Oral
oral
corticosteroids.
corticosteroid, yes, yes, for more than 2 years with the formoterol
Dexamethasone per
budesonide,
year.
yes, yes, yes. So this patient, yes, after this one, it will be good to switch on to this fluticasone furet with the bilanterol combination. So I feel if we rule out all the comorbidity factors, this everything, then surely this patient will be definitely respond if patient is not a case of the true severe bronchial asthma. So I'm
So
saying.
we might not even require to start with the triple drug therapy also. Just the
Yes,
dual
yes,
drug
yes, yes.
therapy would have
Uh,
been enough.
yes, yes, yes. And then yes, we may yes, if not respond, then we may shift on to
Yeah,
biologic,
then we
and
can
then
escalate.
yes, 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 escalate also. Yeah.
Thank you, sir. Thank you, sir. Dr. Jayashree, would you like to add?
No, I would agree. Like, yeah, we will first switch to this fluticasone furoate and bilanterol combination first, and then also if the patient is like still having the persistent symptoms, uncontrolled symptoms, then we can escalate to the triple therapy.
Thank you. So we'll move to the next. So do you think switching to this fluticasone bilateral combination can help delay consideration of biologics in uncontrolled asthma patients? Now we are coming to the topic of biologics. So Dr. Jayashree, what is your view regarding the use of biologics and whether this fluticasone bilateral combination will they do you think that they will play a role in delaying this use of biologics in uncontrolled asthma patients?
Yes, I think that switching to this combination can help us delay in considering the biologics because as we have already seen, like compared to the conventional smart therapy, fluticasone furoate and vidanterone has much more added advantages. But
Mm.
like in certain patients, like who are having certain persistent high eosinophil counts, despite the high doses of inhaled corticosteroids, and the
Mm.
patients who are having frequent severe exacerbations and they are on maintenance OCS, all these phenotypes, maybe we can go for upfront biologicals, but in most of the patients, I think we can first try switching to this fluticasone and vilanterol combination before going for the biologicals. Except in certain group of patients, which I have already mentioned, like those with the high eosinophil counts, like those patients who are expected to show a better result when biologics are initiated early. But rest of the patients, I think we can first think of switching to this combination before going to biologics.
Yes, and yeah, since biologists we all know are quite expensive, and not everyone can afford it. So yes, we should first think about switching to this dual drug combination, and if not controlled, then we should still consider with the triple drug therapy, and if not controlled, then only we can think out of role of biologics, right? So, Dr. Wilu sir, would you like to add your comment?
Yes, I agree to that. Yes, yes. Dr. Zesri, what she say also, yes. Yes, we can first this one start with this one fluticasone furet with
And the
bilanterol,
bilateral
and then
combination.
yes, yes, and we can see the response also. Yes, and in that way, definitely we can delay this one starting of the biologic. as you said, biologic is very
Expensive.
costly drug, yes, expensive drug, and then it's not easily
Not easily available also.
available also.
Mm.
And then yes, I don't know for others. Then I have not much experience of using this biologic mepolizumab and then this omalizumab and this benralizumab. No? So I have limited
Mm.
knowledge also. But yes,
Mm.
we can switch to this fluticasone furoate with bilantrol. Yes, before the starting of the biologics. Yes, this will definitely delay the starting of the biologic.
I also agree with the comments of the uh, other uh, others trying this one molecule before biologics.
Yes, sir. Thank you, sir. So now, yeah, how do we foresee the treatment algorithm changing with the use of this fluticasone bilateral in uncontrolled asthma? And where does this combination fit into the Indian asthma guidelines and how this might evolve in the future? So, what is our view regarding the use of this new drug combination in the treatment algorithm, especially in uncontrolled asthma? And what is our view in the Indian asthma guidelines? Nagendra, sir, would you like to comment?
Actually, as the efficacy of this molecule we are being using for quite a long time now, we have been very confident and using for the symptom control and the longer acting improving the lung function, and it is a very much bright uh, place for its inclusion in India as my guidelines, uh, probably which may have to be included early in the evolving guidelines. I I expect so.
Yes, sir. Dr. Wilu, sir, would you like to add?
Yeah, for every this one, this uncontrolled asthma, yes, we can this uh, switch to this bilateral with fluticasone furoate, and then yes, this think yes, when we consider all the advantages of this molecule, no? So it has yes, it can really do very well in asthma patients. So I think in as I have said earlier also, it will be a game changer. In afterward in futures, we may yes this use this molecule, no, the vilantroid this fluticasone furoate in uncontrolled asthma patients, and then this will be yes what to say in futures this will be the preferred choice for even for the newly diagnosed case of the bronchial asthma patient also because all the good things about the molecule, what we want in a molecule for treating the bronchial asthma, no, it's all there. If we exactly see about the
Like
yes,
like
yes,
the introduction of new track.
yes, yes,
We
yes,
already
even
have two tracks, right, for the treatment of
yeah,
bronchial asthma.
uh-huh.
Yeah, so this will
So
maybe become the third track.
yes, this will definitely yes for even yes starting the upfront no, for treating the bronchial asthma
Hmm.
patient also, and then yes,
Yes,
definitely yes for the uncontrolled bronchial asthma also yes. When we consider all the
yes,
advantages
Dr.
of the
Tesing.
molecule, yes. Mhm.
Yes,
Yes,
sir.
I
Thank
would
you.
also agree. Like this dual combination, it provides more promising result. Instead of our like in the previous track, we are just escalating our dose of ICS. So
Hmm.
instead of escalating the dose of ICS, we are coming up with a better molecule. I think
Hmm.
this we are seeing this in our future. We'll be seeing this combination in our future guidelines. I hope this will be coming up very soon.
So, so this combination it has a more like a good role, especially in the step 3, step 4, right?
Three step.
And yeah, as I was just suggesting, yeah, it can evolve into the third track. Already we have two tracks. One is the formoterol ICS combination, one is the other lavas. So this can become the third track with a like the we have the smart therapy. So this, since it has a better adherence and a better longer duration of action and also a faster onset of action when compared to the formoterol combination, so this can become also the new smart therapy actually. So we'll go to the next. So with all the evidence discussed till now, so this two combination, can it be used as a first choice ICS lava in uncontrolled patients instead of escalating dose of formoterol budesonide? This is the first. And can this be used for maintenance treatment, especially in the step 2 and step 3? So this is exactly what we have been discussing. So Dr. Jesse, would you like to comment?
I think this question has already been answered. So definitely
Yes, we have already discussed.
we can definitely go as a first choice for this dual combination. So also in
Mhm.
treatment naive patients, we can go upfront with this molecule definitely.
Hmm. So as a maintenance, we can also say, we have a good experience with this drug. So we can, yeah, we can. I feel that we can still use it as a maintenance. Dr. Nagendra, sir, would you like to add?
Yes, yes, definitely. I agree with it.
Yes, sir. Thank you, sir. Dr. Wilu, sir.
Yes, yes, I agree. And some of my patients, they are using these two molecules, yes. And then they are, yes, doing very well also. So I, yes, have now very, yes, yes, trust on this molecule. And then, yes, yes, we can definitely use for this purpose, yes, yes.
Thank you, sir. So I guess we have almost discussed almost all the importance, the what the advantages of this combination as compared with the formatal budesonide combination, and we with all the esteemed panelists talking their sharing their experiences. It was a nice experience, nice panelist discussion, and I guess that's the end of our evening session today. Thank you very much. Thank you all the panelists.
Thank you.
Thank
So
you.
thank you so much,
Thank you.
Dr.
Thank you.
Ronald. Thank you so much, Dr. Jayashree, Dr. Deka, and Dr. Vilubu. I think this was one of the most uh, in-depth discussion we have had so far. And compliments to Dr. Ronald and as well as to all our panelists for, for like my appreciation because everyone has shared their experience, rich clinical experiences, and I'm sure whoever has attended this session, your clinical experiences are definitely going to help them in their practices. And just for your information, there were more than 400 attendees who were part of this live webinar. So this was all from our end, and thank you so much for your valuable time and your valuable contribution. Thank you.
Thank you.
Thank you.
Thank you.